This is Walter Kemp. This lecture is Aneurysms and General Features. The first slide, this is actually along Highway 56 in the northwest corner of Montana. It's one of my favorite highways to drive when I used to drive home from Missoula and stuff. Very, very scenic through there. And then I also am having a little bit of a cold today, so I sound a little bit funny. Sorry about that. So like I said, this is Aneurysms General Features. There'll be 3 lectures on aneurysms. There are the websites that me and Dr. Hughes have for questions. Each one has I think 2, 3, 4, 500 questions. My Twitter, which I keep saying I'll get started again, I should hopefully this weekend. And then, like I said, I'm a forensic pathologist, but I have a very strong interest just in general and organ pathology of all types, and I really enjoy teaching medical students. Here are the disclaimers. Please read these disclaimers. If they apply to you in a way that would make you not watch the lecture, then don't watch the lecture. And then third disclaimer also. And then the last one is just in case you're interested in my teaching style. It's in the introductory presentation, but not very many people watched it. That's okay. So here are the references that I'm using. I start each lecture out with a question or two. This time there's 2 questions. The idea is that it makes you key in on the lecture to certain things and increases your retention time. And this is a tough question, I will say. And then next question. And once again, we'll go through these at the end. So just pause, look at it, see if you can come up with the answer, and then we'll go through it at the end. So basically, an aneurysm is an abnormal dilation of the wall of a blood vessel or heart. You can get aneurysms of blood vessels, and you can also get an aneurysm in the heart after a myocardial infarct. When you have a transmural infarct and the wall thins out, it can actually be aneurysmal. And then that dilation can either be a saccular, like a bulge in the side, or just a general fusiform dilation. So the type of aneurysm, there's true and false. It's based upon the wall structure. This is also useful for diverticuli in the colon. Remember, colonic diverticuli have basically mucosa, and then Meckel's diverticulum has all 3 layers. So a true aneurysm, which most of them you're going to talk about are true aneurysms, and then a false aneurysm actually is due to a defect in the wall that allows blood to leak out, and that blood gets on the adventitial surface and looks like an aneurysm because it looks like a bulge, but it's not. So like I mentioned before, saccular or fusiform. So the top right is a saccular aneurysm. The yellow box squares off. This is in the distal aorta, at the bifurcation of the iliacs. To the right of the image has that. Although it's tough to make it out, that's why I'm saying that. And then the bottom left is a fusiform. That aorta is generally dilated in size, but there's no specific bulge on each side of it. There's other ways they talk about them too. It can be based on the cause, so like atherosclerotic, or if it's mycotic, location, thoracic aortic aneurysm, abdominal aortic aneurysm, and that. So general clinical findings associated with aneurysms. So if you just think about it from an anatomic perspective and just basic anatomy, just think about where it's at and what it could push on, stuff like that. So if the aneurysm is a saccular outpouching of the wall or a fusiform dilation, it could be weak, and then it can rupture, and then that could rupture into the cavity. It could be, if it's a thoracic aneurysm, it could rupture in the left pleural cavity, pericardial sac. Abdominal aortic ruptures in the retroperitoneum, and that breaks loose in the peritoneum, and so you can see that. Pulsatile mass, you can feel in a potentially abdominal aortic aneurysm, although I always thought kind of crazy that people would palpate them. You'd think that if it's weak and could rupture, that it could rupture. Compression of adjacent structure. So like a thoracic abdominal aortic aneurysm could push on a range of things. It could push on the ureter and cause renal failure potentially. It could push on the colon potentially and cause an obstruction. Could push on renal artery, cause infarct of the kidney. So these are things to think about. Think about what's around it. What could it push on? The thoracic aortic aneurysm will get in that, but it can push on things like various nerves. It can push on highlight of the lung. It can cause potentially obstruction, leading to pneumonia, stuff like that. So it kind of helps you, if you think of the basic anatomy of it, you can kind of think through what some of the complications of it might be. And since you have thrombus and oftentimes plaque and stuff inside of this aneurysm, it's pretty friable. It could break loose and embolize. So this is hole number 1 at the golf course where I grew up in Libby, Montana. My grandfather was actually the first person to get a hole-in-one and the first person to get 2 hole-in-ones, and I have 0. So this was hole number 1. So 3 examples of clinical findings associated with aneurysms. The first slide is 2 of them. Second slide is 1. So the top left, what you see, the black arrow, you can see that blue, that's the pericardial sac. So the pericardial sac is full of blood. So if you have a thoracic aortic aneurysm, that ruptures into the pericardial sac, you can get a hemopericardium, and that could lead to a cardiac tamponade, which can cause failure really quick. The heart can beat, but it obviously can't dilate to fill with blood, and this would cause something where they say pulseless electrical activity. It's generating a pulse. It's generating electrical activity, but it can't generate a pulse because it can't dilate because it's surrounded by blood in that pericardial sac, making it tight, and then it can't fill with blood to pump it out, so there's no pulse. And the bottom is the retroperitoneum. The intestines have mostly been removed. The small intestine's been removed. Large intestine's still there. But you can see that hemorrhage, the black area on the bottom right. So that was a retroperitoneal hemorrhage from a ruptured abdominal aortic aneurysm, and that can bleed into that, and then ultimately can rupture into the peritoneal cavity, although I've seen people who have died basically just that hemorrhage in the retroperitoneum. So this person presents with back pain, he has a history of hypertension, older male, smoking. This would be something to strongly consider. So the third one I show is this one. This was an individual who had a abdominal aortic aneurysm. The yellow star at the top is the aneurysm, and that what looks like muscle, that's actually thrombus. To the left of it is the actual non-aneurysmal aorta above the renal arteries, and you can see there's still pretty good atherosclerosis there. And then the red arrow shows a stent. So what happens is this person's aneurysm pushed on their renal artery and caused an infarct of it, and that's what's in the bottom right. So all those kind of yellowish tan areas, that's all infarct. They did have pretty significant atherosclerosis. You can see that at the very bottom with the white arrow. So it probably didn't require much pressure on that for it to be completely occluded and infarct the kidney. So those are just three clinical things that kind of show, think about the anatomy, think about what's around it, think about how the patient might present and stuff like that. Okay, so the questions, like I said, so pause it and then answer it, and then we'll go through it, and we'll do the second one. A 60-year-old male with a history of hypertension and 75 pack-year smoking history presents to his family physician for an annual examination. Physical examination identifies a pulsatile mass in the abdomen. Evaluation of which of the following laboratory tests could be directly related to the patient's disease process. So the one I was looking for is blood urea nitrogen. So what I just showed you there was the person infarcted their kidney. So if they have an abdominal aortic aneurysm, which would be the pulsatile mass in the abdomen, that could pinch on surrounding structures. It could pinch on the artery and cause kidney injury and cause potentially an elevated BUN. So one thing about my questions, these are not necessarily all ones that would make it through all the 4 committees for the USMLE, but they're designed to just make you think about the material and everything like that. So, okay, second question. Okay, so a 61-year-old male with a history of hypertension has an episode of lingering sharp chest pain but does not seek medical attention immediately. 2 days later, his wife finally convinced him to see a doctor. A CT scan of the chest reveals a local dissection of the descending thoracic aorta with a large bulge of hemorrhage adjacent to the aorta. Of the following, which best describes the lesion identified on CT scan? So the answer would be false aneurysm. So where they had a dissection, it ruptured out, but it was contained by the adventitia and the surrounding fat. So it made basically a bulge of fat, a bulge of hemorrhage outside of it, but that little bulge is going to look like an aneurysm potentially. So this is a false aneurysm. So, and as usual, at the end of the lecture, use reflection. So go back through and think of what are 5 points that you remember from the lecture. And this is a really good way to kind of cement the material and retain it better using this technique. So at least I hope you learned 5 things from the lecture. So I hope these lectures are good and useful to you, which I know some people have been responding sometimes with comments and stuff like that. I'm always open to comments to help improve or anything like that. I really want to provide the service to the students to provide something good for you all to use and everything like that. So please let me know. This is the Cabinet Mountains. This is up in northwest corner of Montana. This is where I grew up at. So I hope the lecture was useful for you, and thank you.